Let's get started. So we will try to finish both the granulomatous inflammatory and the granulomatous neoplastic entities, not really neoplastic, but like lesions. Uh, so coming to your granulomatous diseases, so we have graduated from your papillosquamous diseases to dermal-based lesions. So granuloma is one of the difficult topics that you guys encounter, just because the entire histologic recognition of a granuloma can be challenging. So these often look like nodular aggregates in the dermis, and typically granulomatous diseases should not give you any epidermal involvement, with exception of Langerhans cell histiocytosis, which is an epidermal disease, as we will see. Now, granulomas, which are collection of histiocytes, are classically divided into, based on their morphology, into sarcoidal, tuberculoid, palisaded, and suppurative granuloma. So we will talk about all of them in detail. So sarcoidal granulomas are classically described as naked granulomas, which basically means that they predominantly contain a collection of epithelioid histiocytes. Now, it does not mean that they don't have any lymphocytes within them. They do have lymphocytes. The lymphocytes can be present surrounding these lesions or as a sprinkle within the lesions. But they are classically referred to as naked because they are predominantly a ball of just these pink histiocytes. The best way to recognize them is not to get distracted by the lymphocytes, but to see if you can form a nice tight fist. These look like these pink fluffy aggregates, then you're dealing with the sarcoidal granuloma. You will almost in every sarcoidal granuloma see these multinucleated giant cells, as you can see in this lesion. The prototypic disease that produces sarcoidal granulomas is sarcoidosis. So in sarcoidosis, typically the granulomas are present in a lichenoid distribution in the upper and the mid dermis, but you can also see them in the deep dermis, and very rarely you can have sarcoidal granulomas presenting as a paniculitis as a lobular paniculitis, which is called the Dario-Rouzy variant of sarcoidosis, which is rare. So these are sarcoidal granulomas. You can see that they are nice right nodular pink aggregates, which you are present in the dermis. The next slide that I'm going to show you is like the classic for sarcoidosis, wherein the papule presents with this lichenoid distribution in the upper dermis. This is very classic. The way these sarcoidal granulomas, they abut the epidermis, are present parallel to the epidermis. This is very classic for sarcoidal granulomas. And you can see that there is an accompanying perivascular lymphocytic infiltrate, which sometimes can be predominant and can look challenging. You don't want to call it if you see a whole lot of lymphocytes, but that's not the case. So you can see that there is a good rim of lymphocytes surrounding this sarcoidal granuloma, but this is a nice tight round fist. So this would be a sarcoidal granuloma. Now, it's important for your boards to recognize the sarcoidal granulomatous dermatitis, which is not sarcoidosis. So things that mimic sarcoidosis. The classic one is your foreign body. And the most common one is basically a polarizable foreign body like silica. So you can recognize it to be sarcoidal granulomatous reaction based upon the extent and distribution of the sarcoidal granuloma. So like the way the specimen is taken. So this is like a deep punch, or it would be an excision specimen. You see back-to-back packed sarcoidal granulomas. And very often on low power, there will be holes and spaces in the tissue. So you see these kind of shreds and spaces in the tissue. When you go up on high power, these pieces you will have to look around will contain this fragmented foreign material, which is actually polarizable. But because you're not looking it under the microscope, it's much more easier to recognize because it is very refractile. But you don't have the advantage of doing that on your on a digitalized slide. So you really have to go with the reaction pattern. Back-to-back sarcoidal granulomas with central fibrosis, deep dermal location, and then these holes and spaces in the tissue, and you have to go up on higher holes and spaces. Not all of them will contain the foreign material, but you will have to look around, be a little patient, and you'll be able to find the foreign body. But you can see that the background are all these sarcoidal granulomas, which are these nice nodular aggregates, these tight aggregates. There's a good lymphocytic infiltrate also associated with it. Now, sarcoidal granulomatous dermatitis can also be produced by non-polarizable foreign material, and the classic is beryllium and zirconium, and those will look indistinguishable from sarcoidosis, and you will not be able to see the foreign body in the slide because it does not polarize. So you have to have a very high index of suspicion for those diseases. So remember beryllium and zirconium. The next would be the sarcoidal granulomatous dermatitis, which arises in the background of tattoos. So you can see here there is nice tattoo pigment. This is predominantly the black tattoo, but you can see that there are sarcoidal granulomas which are arising in the background. Now, these patients who develop sarcoidal granulomatous reaction in tattoo pigment have a sarcoidal diathesis. So, which comes first? Is this a tattoo, or does the sarcoidal granuloma, or does this patient have true sarcoidosis? You don't know. So you cannot predict that. Most of the times I've seen that patients who develop lesions like sarcoidal granulomas in tattoos probably will go ahead and develop sarcoidosis. So the only thing which you can report is sarcoidal granulomatous dermatitis from the tattoo pigment, and it's important to just not say foreign body reaction from tattoo, but specify the kind, which is a sarcoidal granulomatous, because that is important. So these are sarcoidal granulomas arising in the tattoo pigment. The most immunogenic is actually mercury. So the cinnabar, the red tattoo pigment, is the most immunogenic. So you can see here the nice sarcoidal granulomas, and there is this background pigment, which is actually cinnabar. It is not really looking red over here, but it is actually red. So this is the sarcoidal granulomatous from a tattoo pigment. Okay, now let's come to your next kind of granuloma, which would be your tuberculoid granuloma. So tuberculoid granulomas, on your first look, they will not look like granulomas because they look like these blue and pink balls. So they look more blue than pink. But these are expanded nodular aggregates, which are oriented perpendicular to the epidermis, growing along the neurovascular axis. So they look like bag of worms. So you can see these expanded infiltrates. So typically, when it is just lymphocytes, they are just blue, right? But if you see blue and pink within an aggregate, then they have to be histiocytes. So all that pink stuff in among the lymphocytes is actually histiocytes. So these expanded aggregates oriented perpendicular to the epidermis, growing along the neurovascular axis. Now, these tuberculoid granulomas, classic tuberculoid granulomas, do not contain a predominant neutrophilic infiltrate. If tuberculoid granulomas contain a very predominant neutrophilic infiltrate, you put them in the category of suppurative granulomas. And that is important because your further diagnosis of disease and your further workup is based on the true identification of a tuberculoid versus a suppurative granuloma. So the classic tuberculoid granulomas do not have a predominant neutrophilic infiltrate. If they do have neutrophils, they are difficult to find. It's only after careful searching that you will be able to see neutrophil. They're not very predominant. So they look more clean. Now, the two diseases which you think about when you see tuberculoid granulomas are tuberculoid leprosy and syphilis. So tuberculoid leprosy has a very low bacillary load. Patient's immunity is really good. So you are not going to really see the organism readily. We often have to do multiple levels and stain it up for stain and spend like a lot of time looking for those organisms. The best way is to not culture. So this is another question that they can ask you. Mycobacterium leprae does not culture. So you have to do PCR analysis to be able to detect the Mycobacterium leprae organisms. The PCR analysis can be done on your tissue block. So it doesn't need to be fresh tissue. So you can just send the tissue block. So you can send the tissue in formalin, it will work. So that is the next step if your fight stain is negative. So this is from a patient with tuberculoid leprosy, and this basically looks like these expanded pink worms, which are going perpendicular to the epidermis along the neurovascular axis, presence of perineural inflammation, which we don't see in this case. But if you see inflammation around the nerves, granulomas around the nerves, that's also very indicative of tuberculoid leprosy. One other disease that can do that is post-herpetic granulomatous inflammation. So post-herpetic granulomatous inflammation can look like tuberculoid leprosy because it produces that perineural inflammation with tuberculoid granulomas. But that is not a very common both testable entity. Really, when you see a tuberculoid granuloma, the two things you think about are tuberculoid leprosy and syphilis. So how do you think about syphilis then? So you can see this is another biopsy, and you have the same thing. You have these expanded worms, these bagger worms, these pink and nodular aggregates oriented perpendicular to the epidermis. And when you go up on high power, within the tubercular, so the next step is when you go up on high power. Within the tubercular granuloma, if you have plasma cells, so you can see there are numerous plasma cells in this infiltrate, then that is pretty much syphilis. Another thing which syphilis does is that if you start paying attention to the lymphocytes, they will always look atypical. They're always very reactive appearing. So the spirochete organisms, they do that to the lymphocytes. So if you start seeing a lot of lymphocytic atypia in the background of a plasma cell infiltrate, and even scattered neutrophils can be seen. But again, the neutrophils are never a predominant finding in the biopsy. It's mostly the plasma cells. That would make you think about secondary syphilis. Secondary syphilis most often presents with this reaction pattern, but you know that secondary syphilis is a great mimicker. So it can present with a lot of other reaction patterns as well, which I'm not going to talk about today. When we do infections, we will talk about what all other reaction patterns can syphilis present like. But this by far is the most common one, that is a tubercular granulomas with plasma cells. And then the next step you will do for this particular patient is to do a Treponema pallidum immunostain. So that is an immunohistochemical stain, which again can be done on your slide itself. And different labs use different chromogen for staining the spirochete organisms. I'm very fortunate that in our lab we do the red stain, so which will nicely highlight the spirochete. The brown is very problematic because it will mimic melanin granules in the background. So this is red, and you can see that it is nicely highlighting these organisms. The best place to look for the organisms is at the dermoepidermal junction around the hair follicles, and those are the best places that you will look for these spirochete organisms. So the next step, if you're suspecting it, is to do the stain. Okay. And things like Wharton starry stain, we don't really use them. They are extremely difficult to interpret. So it is the Treponema pallidum immunostain, which is the correct answer. Okay. Now let's go to our next reaction pattern, which is, so we have talked about sarcoidal granulomas, we've talked about tubercular granulomas, and now we're talking about suppurative granulomas. So suppurative granulomas are the ones which you will like instantaneously not recognize it to be granulomatous. It just looks like a really busy dermal differential. And when you go on, the epidermis can be variable. The epidermis can be normal. The epidermis can be hypertrophic. The epidermis could be eroded or ulcerated. So epidermal changes are variable. The infiltrate in the dermis could be superficial. It could be superficial and deep. It could be deep. It could be anywhere. But when you go up on high power, it is very busy. You do see a predominant neutrophilic infiltrate, which is easily recognizable. So you see these numerous neutrophils. And then in the background, you see all these histocytic cells, these pink cells. And very often you will see giant cells as well. So that's a suppurative granulomatous dermatitis. When you look at a suppurative granulomatous dermatitis, that equals an infection. So that means this is infectious. And what are the organisms that will do this, which will produce this reaction pattern? Among the bacteria, classic bacteria like furuncle or your staph organisms do not do this. So when you see a suppurative granulomatous dermatitis, we always do a gram stain for those organisms, but this is not the reaction pattern of what a staph aureole mediated infection like a furuncle would do. This can be produced by your atypical mycobacterial organisms and your mycobacterial organisms. So MTB and atypical mycobacterial organism. That's the bacteria that would do it. Miyawki's granuloma, which is your type of tinea infection, will also do this, produce this reaction pattern. And then you have your deep fungal infections. So among the deep fungal infections are the ones like Leish or Leishmaniasis or histoplasmosis, blastomycosis, coccidio, all those organisms which we will talk in infectious diseases. So there are two scenarios. When you have a suppurative granulomatous dermatitis, you either see the organism or you don't see it. Okay. If you're seeing the organism, then the diagnosis is obvious because it could be either the fungus, which is Miyawki's granuloma, or it could be one of those deep fungal, which I just mentioned, right? The diagnosis of which we will talk about when we will do infectious diseases. The problem is when you don't see the organism, which is what the slides that they give you. When you don't see the organism, that's when you think about mycobacterial and atypical mycobacterial infections. So what are the mycobacteria and atypical mycobacteria that can do this? So MTB, I told you. Then atypical mycobacterial infections like Burulli's ulcer, which is your Mycobacterium ulcerans, your Mycobacterium marinum, which is your swimming pool or fish tank granuloma, Mycobacterium chiloni and fortunatum, Mycobacterium kansasi, and then Mycobacterium avium. Now, out of this, the most common is chiloni and fortunatum. So those are the most common causes of your skin infection following wound contamination. Mycobacterium kansasi is extremely rare in the skin. It's most common in lung and lymph nodes. And Mycobacterium avium is an AIDS-defining illness. So it is also very rare in the skin. It most commonly involves the lungs. So uh, what are the next steps that we do when we see a suppurative granulomatous dermatitis, which is very worrisome for an infection? And those are the questions they can ask you. What's the second step you would do? So you will throw in a bunch of infectious stains. We typically will do the PAS, Gram, GMS, acid fast and fight to cover all bacterial, atypical mycobacterial, and the fungal infections. So PAS, Gram, GMS, acid fast and fight. What we are specifically interested in when we don't see, I can tell you, in most of the instances where it is a Miyawki's granuloma or it is one of those deep fungal infections, you can see the organism. You really don't need to do, very rarely do you need to do a stain to be actually be able to see it. We just do the stains to confirm it. Uh, but when you're not seeing it, then it's almost always you're dealing with the mycobacterial or atypical mycobacterial organism. And we have to do the acid fast and fight and look at it. And if we don't see any organism on there, then we recommend tissue culture. The culture in this case has to be fresh tissue culture. So, culture always has to be fresh tissue culture. And then if that doesn't work, then we recommend PCR analysis. But PCR in this case for Mycobacterium TB and atypical mycobacterium, you can do it on the paraffin embedded block, but it has a very low yield, unlike your Mycobacterium leprae. So you always recommend fresh tissue to be sent in for PCR. So I hope that kind of an algorithmic workup is clear in your head because they can ask you questions regarding it. As far as your slide is concerned, there's nothing spectacular about the slide, right? It's a suppurative granulomatous dermatitis with a variable epidermal involvement where you don't see the organism. That's when you think about MTB or those atypical mycobacterial. And any one of them could be a multiple choice, right? But if they have more than one, then, they have to give you some second order question to be able to pick it up because all of them will look same. So this was from a patient who I think grew Mycobacterium chiloni. Then you have this is another one. This is a suppurative granulomatous dermatitis, which presented as a nodule. And you can see that the epidermis is unaffected. And in the subcutaneous tissue is actually where you see this big nodule. This is called caseation necrosis. So when the center of the specimen becomes purulent and necrotic with this pink debris, that's caseation necrosis. That's very suggestive of tuberculosis infection, but it could be any atypical mycobacterial. So you largely recognize this with the reaction pattern. Okay, so hope that was clear. The next thing we're going to talk about is uh, something which is not that important for your boards, but you should know it. So this is a nice punch biopsy, and you recognize that this is a place where there are a lot of pilosebaceous glands and small hair follicles. So this is likely the face. And what you see in here is lots of background telangiectasia. You see these telangiectatic vessels, and you see tuberculoid granuloma. So if a granuloma is not sarcoidal and you're recognizing it to be a granuloma, you use the terminology tuberculoid granuloma, right? Because it has an aggregate of histiocytes and lymphocytes. So this is a tuberculoid granuloma, and it is present around the hair follicles and around the vessels, but mostly around the hair follicles. And when you go up on high power, there is a little sprinkle of neutrophils in here, as you can see in here. There are also neutrophils which are going up into the epidermis. This is not an infectious granuloma, but this is how granulomatous rosacea will look like. So granulomatous rosacea presents with a non-specific reaction pattern so granulomatous rosacea can be either nothing. When you do a biopsy, it could either be just telangiectasia and sparse inflammation, or it could be very exuberant, like this. You can have tubercular granulomas with neutrophils around the hair follicles and around the vessels. Most of the time when you're biopsying for rosacea, you want to make sure it's not something else. Like you want to make sure it's not contact derm, especially lupus, right? So that's the reason you're doing the biopsy. So most often it's like kind of like a diagnosis of exclusion. However, there is one kind of granulomatous rosacea, which is a really important board question, and it almost always is asked on your boards, and that is lupus miliaris disseminatus fasciae or acne aggminata. So in lupus miliaris disseminatus fasciae, you see one large granuloma with central caseation necrosis, which is folliculocentric. It's around the hair follicle. So number one is it's one big granuloma. Number two is it's a big granuloma. And it has central area of this pink necrosis, which is caseation necrosis. And this is actually following the path of a follicle. So you may see the follicle, you may not see the follicle. Okay, so in this case, I can presume it's the path of a follicle because of the way the granuloma is oriented, but I'm not seeing the follicle. But it does look pink and necrotic. It will have like neutrophils in it. So, and that is the reason people, it has the word miliaris in it, but it's not tuberculosis, and it's certainly not lupus. So the name is misleading. It's lupus miliaris disseminatus fasciae, which is a variant of granulomatous rosacea, wherein patients present with monomorphous papules in the central portion of your face most often, or acne aggminata. When we see this, it's so classic in appearance that we do not even need to stain it up. There is no reason to stain it up. It's not infectious, even though it looks infectious. So this is lupus miliaris disseminatus fasciae or acne aggminata, which is a very important board question. Okay, now let's go to our next kind of granuloma, which you guys are all familiar with, which are palisaded granulomas. So palisaded granulomas are granulomas where essentially something dies in the dermis and then your infiltrate is collecting around it. Okay, so cell death is an important component of a palisaded granuloma. So based upon what is dead, and how does the dead material look like, you are classifying the palisaded granulomas. So the palisaded granulomas could be GA, in which there is dead collagen in the center, which often accumulates mucin. Okay. Then you have necrobiosis lipoidica, which is again dense sclerotic collagen, but it doesn't have mucin, but the collagen looks different from that of GA because it assumes a dense pink morphology. So it is very sclerotic. It's very pink looking. And then you have rheumatoid nodule, where the central necrotic stuff has a fibrinoid look to it. So it looks more destructive. It's more fibrinoid in appearance, and it is often accompanied with a lot of dust and not neutrophilic, but it's broken nuclei. So it looks like kind of more dirty. It doesn't look pink alone, but it has a little bluish tinge to it because of all the leukocytoclasia. So those are the three most common type of palisaded granulomas you deal with. So you have GA, NLD, and rheumatoid nodule. This is classic example of a GA. So the dorsal aspect of the hands is not a bad location. So you can see the thick skin. And what you see is a palisaded granuloma with the central dead stuff, the necrobiotic collagen, which has a subtle mucin in it. And mucin by no way is required to make the diagnosis of a GA. If you see it, it's good. If you don't see it, it's again good. But the location of the granuloma, you can see that there is palisaded infiltrate of inflammatory cells around it. The inflammatory infiltrate can have giant cells, it can have neutrophils, it can have eosinophils. The best way to recognize GA is low power. If you go up on high power and go directly into the infiltrate, you will get confused and you will go down the wrong path. So the best recognition is on low power. So I'll show you some more examples of GA. And the granulomas in GA are always going to be very randomly distributed. And that's one of the most distinguishing feature from NLD. So you can see here, there is one granuloma here, there is one granuloma here, there is another granuloma here. And this one actually has very nice mucin in the center. Here you can see the nice palisaded where the collagen bundles, are swollen. You can see that. So that is GA. Now, another thing about GA is remember that on low power, sometimes when you look at it, it can give you a very predominant lymphoid infiltrate. So for example, if you were to look at this biopsy, if you're not paying attention, you'll get like this. This is a very tight cuffed infiltrate. So you'll go down the wrong path if you do not pick up this. So this is your GA right here. So GA can present with a nice superficial and deep perivascular lymphoid infiltrate, but there is GA here. So it's always important to stay on low power for recognizing GA. One variant of GA, which is pretty confusing, which is actually never diagnosed clinically. Whenever you biopsy patients for this, you're always thinking about either something like, it's either you don't know at all what is happening or it comes in as like CTCL, something vague. Like I can never understand what it looks like clinically because it has such varied morphology. And that is interstitial GA. So interstitial GA is actually a pretty simple histologic diagnosis to make, because when you see it under the microscope, it looks like really busy dermis. And it looks like busy dermis, so there is lots of perivascular inflammation, but then the collagen looks swollen. And you see when you go up on high power on the area of swollen collagen, you see these lymphocytes, histiocytes, and giant cells which are palisading around individually necrobiotic collagen bundles. So instead of producing a whole discrete big area of destruction, the individual collagen bundles are swollen and necrobiotic. And that's where the inflammatory cell infiltrate is wrapping around. That is interstitial GA. However, beware of interstitial GA, because if there are tumors that can mimic interstitial GA, which you don't want to miss. So whenever you are thinking about interstitial GA and you go up on high power, make sure that the morphology of the cells is correct for GA, means that they are lymphocytes and histiocytes for sure and not tumor cells. And second thing is that it is not overtly cellular. So something which is very cellular in appearance is not likely going to be interstitial GA. And I'll show you examples of it. But the two most common mimickers of interstitial GA are metastatic breast cancer and leukemia cutis. So they all present with an interstitial GA-like infiltrate. So like this is your biopsy, and what you see in here is busyness in the dermis. So at low power, you may think, yeah, this could be interstitial GA. But then when you go up on high power, you basically see that these are not histiocytes, because you see these cells, they're lining up, forming a line in between the collagen bundles. And inflammatory cells like lymphocytes, they're not that orderly. They never form this kind of line. And also you see that many of these cells, they have these signet ring cell morphology. So they have this intracytoplasmic lumina, which actually contains mucin. So it's like a ring, or it has a bubble in it. There is another very nice signet ring cell in here. You can see that. This is the intracytoplasmic mucin with the nuclei right adjacent to it. So it looks like a signet ring. This is the classic morphology of a metastatic adenocarcinoma to the skin, which most often is from the breast, and but other sites such as the lung or even the stomach can do that. Gastric carcinomas can also do that. So this is metastatic adenocarcinoma. This is from a patient with metastatic breast cancer, and this is the most common type of morphology you see for metastatic breast cancer, wherein this is called the Indian filing pattern, where they are lining up in a line present in between and among the collagen bundles. The other entity which will do this is leukemia cutis. And in leukemia cutis, the specimen will appear much more cellular. So you can see that this here is very, very cellular. But the top portion does look like GA, because even the infiltrate has incited like a mucinous reaction. But this is just too much for GA. You see the degree of cellularity. And when you go up on high power, these cells can look very much like the breast cancer cells. And that's always your problem. So you mistake leukemia cutis for breast cancer and vice versa. So essentially, the trick is to basically recognize if you're seeing the signet ring cells or not. And another trick is that in leukemia cutis, which most often involves the skin, is the M4 subtype, which is a myelomonocytic kind. And these leukemia cutis cells, they always have cytoplasm around them. So you can see that many of them actually look like those fried eggs, except that they have really big nuclei. So they have some degree of cytoplasm around them. There can be other cells like EOs present in the background, as you can see in here, and they do not show the very nice Indian filing. Or even if they show, they will for sure lack the cytoplasmic mucin and the gland formation. So you do not see the signet ring cell. So this is metastatic breast cancer. When we'll do our revision slides, you're going to get plenty of examples to basically recognize which one is which. Is it breast cancer? Is it leukemia cutis? And this particular topic is covered at least 2 more times in other lectures that I give you. So plenty of time to understand this. Okay. The next kind of palisaded granuloma that we deal with is necrobiosis lipoidica. and or NLD. And this is a very organized granuloma. So you see the palisaded granulomas, which involve the breadth and the depth of the biopsy. So from top to bottom and side to side, and they're very organized. So you see layers of palisaded granulomas, layers like this. And the what forms the cream of the layer or the is the necrobiotic collagen, the sclerotic pink collagen. And often at the junction of the dermis and the fat, we often see plasma cells. That's a very classic finding of NLD. Now, what can happen in NLDs as the lesion grows older, this lymphocytic infiltrate can die off, but the sclerotic collagen will remain behind. So you can see if the lymphoid infiltrate goes away, if the histocytic infiltrate goes away, and you just left with sclerotic collagen, this is going to look very much like morphia, right? Because morphia also has sclerotic collagen. So, and it produces that squared biopsy. So remember that morphia and late stage NLD can look similar. So be careful when you're recognizing that. The clue for NLD would be that you will see some histiocytes or giant cells in the infiltrate. And morphia, you should never ever see that, right? You shouldn't see any granulomatous infiltrate in morphia. So this is a late stage NLD. Okay. The last one is going to be rheumatoid nodules. So rheumatoid nodules are most often deep-seated, but that's not always true. You can see things located in the dermis right beneath the epidermis as well. It's the architecture of the lesion and the kind of destruction that is happening that makes a rheumatoid nodule. So you can see that they often have these large palisaded granulomas, which are present back to back with these geographic areas of necrosis. So the necrosis is pretty extensive. And as I said, that the necrosis has this kind of a bluish tinge to it because of a lot of fibrin deposition, which produces the pink thing, and the necrosis, which produces you all this cellular leukocytoclasia, or the infiltrate, the broken down debris of the cells, which gives it a bluish appearance. So these are big granulomas, back to back palisaded granulomas with these geographic areas of necrosis. So that's rheumatoid nodule. This is another example of rheumatoid nodule. This one happens to be located, as I said, in the dermis, which is also fine. But again, you can see these large geographic areas of palisaded necrosis. So that's a rheumatoid nodule. Okay, so those were your inflammatory granulomatous diseases. So we talked about sarcoidal granulomas, tuberculoid granulomas with plasma cells, which is syphilis, suppurated granulomas, which are infectious, and palisaded granulomas. In your PowerPoint handout, which you guys have, there is a detailed description on and the entities that we talked about. In that PowerPoint is also the next heading, which is your granulomatous neoplasms. So what are the granulomatous neoplastic diseases that we deal with? Let me see if I have that presentation open. I don't have it. Let me just open it up. So we covered all that. You should all have this. This is all that we covered. This is all that I was telling you. NLD, this one is the necrobiotic xanthogranuloma, which is also a kind of a palisaded granuloma. This is very unusual that we deal with this disease now because, you know, this gets the paraproteinemia gets detected much more early before the patient looks like this. So these often involve these have these yellowish plaques around the eyes. It can occur anywhere, but the head and neck is a common site. And what you see are the palisaded granulomas with a lot of debris, neutrophilic debris, which wrap around the basically what you see is like something that looks like GA, but very busy because you have all this cholesterol clefts and Teuton giant cells and a dense neutrophilic infiltrate, which produces the dirty bacon appearance. Honestly, I have never seen a bona fide case of NXG. I have suggested it in some instances, but you know, none of it has really panned out. So it's an uncommon disease, one of those exotic diseases that you will deal with. This is what we are going to talk about, the histiocytic neoplasm. So we are dealing with either Langerhans cell driven or the non-Langerhans cell mediated. In the Langerhans cell driven, you have your Langerhans cell histiocytosis and variants of it, like Hashimoto-Pritzker disease, which is congenital self-healing reticular histiocytosis. And then you have systemic diseases like Hand-Schiller-Christian disease, letter C disease, and eosinophilic granuloma. All of them will have the same cells, which are the Langerhans cells, and they will look same, and we will talk about it. And then you have the non-Langerhans cell mediated, which under which comes the JXG variants, reticular histiocytoma, Rosai-Dorfman disease, and then Erdheim-Chester disease, which is extremely rare in the skin. So it is included in that category, but we're not really going to talk about it because it's extremely rare. So let's come to your Langerhans cell histiocytosis. So as I said, that this is probably one of the most common granulomatous neoplasms. Not most common, but it's rare, but it is a granulomatous neoplasm which involves the epidermis. And these are derived from Langerhans cells. So on low power, it looks like an epidermotropic lesion with a lot of erosion and crust. So on low power, you're not really thinking about a neoplastic entity. You're actually thinking about, could this be spongiosis? Could this be psoriasiform, or what is it? But when you pay attention to the infiltrate in the epidermis, you will see many of these cells. These have the classic clover bean or kidney bean shaped morphology with this eccentric nucleus and nuclear grooves and indentations. So these are all Langerhans cells that you see in the background. Let me see, like a really nice one. They look like these kidney bean shaped cells. You can see this with this nuclear grooves and indentation. Often eosinophils will be present in the background. So EOs are a part and parcel of these cells. And these Langerhans cells are stained with CD1A and S100 and Langerin. We do not really need to stain it with Langerin. CD1A and S100 is good enough. And then the electron microscopy of this shows those tennis racket Birbeck shaped granules. So that's Langerhans cell histiocytosis. Okay. Coming to your the next one, which is your non-Langerhans cell driven, the most common is your xanthogranuloma. These are often big lesions, papillonodular lesions, and when you look at it on low power, it's always like first scares you because it's a very big lesion and a lot is happening. And if you jump into the lesion itself, it's very busy looking. So it is a fibrohistiocytic neoplasm. So you will see the background cells, which are lymphocytes. You can see eosinophils. You may even see some neutrophils. But then they have these very histioid-looking cells because they have lots of pink cytoplasm and abundant cytoplasm, vesicular nuclei, and prominent nuclei. So in some cases, you may even think that, oh, these cells have a spitzoid morphology because they have so much of cytoplasm. But when you see the two-tone giant cells in the lesion, then you know you're dealing with the xanthogranuloma. So the presence of the two-tone giant cells, it is basically makes the recognition of this lesion very easy. So this is a beautiful two-tone giant cell. You see the ring of the nucleus with dense pink cytoplasm in the center and the xanthomatoid cytoplasm around it. Now remember that two-tone giant cells are not specific for xanthogranuloma. You can see two-tone giant cells in a dermatofibroma. You can see two-tone giant cells in a xanthoma. So they're not diagnostic of a JXG, but in the setting of this lesion and you're seeing the two-tone giant cells, it makes it an easy diagnosis of a xanthogranuloma. It's a beautiful two-tone giant cell. Now, when you're thinking about a xanthogranuloma and in your boards you see a xanthogranuloma, but you do not see that answer in your multiple choice. So then always remember that you have xanthogranuloma-like entities. So all of these can be asked. So they will all look like a xanthogranuloma, but they have different kinds of manifestations. So typically, the typical scenario is an elderly individual, middle-aged or an elderly individual, male or a female, who presents with multiple lesions and may or may not have some systemic involvement. The most commonly asked one is xanthoma disseminatum. So these patients have disseminated JXG-like lesions, which on biopsy, if you do, they will look like a xanthogranuloma. But these patients also have diabetes insipidus from pituitary gland involvement or epilepsy from meningeal involvement. They may have hoarseness of voice from laryngeal involvement. And this is not associated with any lipid disease, even though it has the word xanthoma in it, but is associated with the paraproteinemia, which could be multiple myeloma, Waldenstrom's macroglobulinemia, or simply an IgG gammopathy. So this is an important board entity, but the histology looks like a xanthogranuloma. And in these patients, you have varying combinations. So you have varying degree of the two-tone giant cells and the background infiltrate. The more mature the lesion is, it is on the classic xanthogranuloma spectrum. The less mature the lesion is, it has the proliferation of those fibrohistiocytic cells and may not have the classic xanthogranulomas. it's now known that whenever we see those lesions, we also add an ALK1 stain, because the type of xanthogranulomas, if they're ALK1 positive, they come under the category of ALK1 histiocytosis, and those entities will have more frequent presentation of internal organ, especially lung involvement, and are in kids. Some of these can also have BRAF mutations, similar to Langerhans cell histiocytosis. So there is some kind of a genetic true neoplastic event in these entities. So those are some of the newer concepts which are arising in these variants of xanthogranulomas. For right now, I just want you to remember the names of this and the fact that the histology can look like a xanthogranuloma, and do read about xanthoma disseminatum because that's the most important one. The next one is going to be your reticular histiocytoma or reticular histiocytic granuloma. It is much less common than a xanthogranuloma, but we often see it. It's not that uncommon. Like, it's not like, oh my God, it's a spectacular diagnosis I'm making. You do see it. And most often, clinical presentation is like a nevus or a BCC. You're thinking like a neoplastic entity. And when you do a biopsy, you will see that, these also, the background have like fibrohistiocytic cells, lymphocytes. But unlike the xanthogranuloma, which had multinucleated cells with the two-tone morphology, these are often very big, binucleated. Most often they can be multinucleated, but most often they are binucleated or a single nucleus, but lots of cytoplasm, which has this amphiphilic tinge. So it has a bluish and the pink tinge. It's a dense ground glass cytoplasm. So they're not really xanthomatized, but they have this dense pink cytoplasm. So this is your reticular histiocytoma. This is the same lesion that you will see in multicentric reticular histiocytosis, which is again an important board question. Those patients will have multiple reticular histiocytic granulomas involving the skin. They also have, especially the back of the hands, they can have progressive destructive arthropathies, endocrine abnormalities like diabetes and vitiligo, or even primary, I think it's biliary cirrhosis, I think the liver involvement that can occur in them. But most importantly is the paraneoplastic manifestation. So, you should remember all those questions. So this is a reticular histiocytoma or a reticular histiocytic granuloma. The last one in that entity we're going to talk about is Rosai-Dorfman disease. So Rosai-Dorfman disease is uncommon, but we do encounter it. And for some reason, it's a favorite board question. I think just because, it's a nice question to ask. The way I think about Rosai-Dorfman disease is when you look at it on low power, it will have a blue and a pink morphology to it. So there will be areas which will look blue, and then you will have the pinker areas. Okay, so let's first back out and understand what Rosai-Dorfman disease is. So Rosai-Dorfman disease is a benign histiocytic disorder, which is characterized by presence of non-destructive phagocytosis called emperipoiesis. So the defining cell in Rosai-Dorfman disease are histiocytes, which are engulfing the other cells in a non-destructive fashion. So within the cytoplasm of the histiocytes, you're going to see other cells, non-destroyed cells like red blood cells or lymphocytes or plasma cells or neutrophils, any cells within their cytoplasm. It's a non-destructive phagohistiocytic disorder. The most common one is not in the skin. It's actually called sinus histiocytosis with massive lymphadenopathy, in which patients present most often with a lymph node involvement, and most common mediastinal lymph node involvement, and hence lymphadenopathy. They also have extra visceral manifestations, systemic symptoms like fever, night sweats, and weight loss. The demographics of that is very different from when it involves just the skin. That one is young patients, most often males, could be Caucasians or African American. When it involves just the skin, that is cutaneous Rosai-Dorfman disease, that happens to be mostly females who are middle-aged to elderly, Caucasians or Asians. And they have a myriad of skin manifestations. Like, I have seen so many different kinds of Rosai-Dorfman disease. The most common one is the one that looks like a DFSP. So it has this keloidal plaque multinodular appearance. But I have seen patients who will have like resistant rosacea-like eruption, a vasculitic eruption, and the most bizarre clinical appearance that you can think about. It could be Rosai-Dorfman disease. The histology, however, is diagnostic. When you take a biopsy, whether it is the systemic variant or the skin variant, this is what you're looking for. You will see the blue and the pink infiltrate, and the diagnosis is in the pink infiltrate. So when you have to go up and higher on the pink infiltrate, And I can understand that at your level, recognition of imperipoiesis is not an easy thing. To me, it is very obvious. So I'm trying to make it as simplified as for you guys. So what you will see is what you can imagine. So what are these? These are all histiocytes, right? They're all like forming like a sea of histiocytes. But all the histiocytes have a non-defined cell border. So what you see, the pinkness is actually produced by a meshwork of histiocytes, and floating in the cytoplasm of the histiocytes are the other cells. So whatever the lighter and the larger nuclei that you see are the histiocytic nuclei. So these are all histiocytic nuclei. They are lighter and they are larger. The smaller nuclei that you see are the other inflammatory cells. So these, most of the ones that you're seeing here are lymphocytes. Very often in the periphery of the pink lesion, you will see plasma cells. So you see lots of plasma cells. This is a very diagnostic clue that you're dealing with Rosai-Dorfman disease. When you see plasma cells at the edge of this pink infiltrate. So that is Rosai-Dorfman disease. And what do these histiocytes stain with? With S100, not with CD1A, but with S100. So when you eventually stain this case, you will see a sea of histiocytic staining cells, which are S100 positive, and inside them are these other cells that are floating. Again, when we do your when I will be sending you your study sets, you will see there are like I have a lot of examples of Rosai-Dorfman disease in my study sets, which you will be encountering throughout the year. So it's not an easy diagnosis. You have to tune your eyes to make it, but otherwise, once you recognize it, there is nothing else. You know that you're dealing with it. So that's Rosai-Dorfman disease. Okay, so now we are going to talk about some diseases which can mimic granulomas. So the most classic among them is your AFX. So the reason I include AFX in here because it is a malignant fibrohistiocytic neoplasm, right? But because it can have a lot of giant cells in it, sometimes you may mistake it for a granulomatous, benign granulomatous entity, which would be a disaster, right? Because it's nothing benign. So the low power appearance of an AFX is very classic. You see a very dense spindle cell neoplasm which abuts the epidermis, almost looks like it is arising from it. This is always very classic for an AFX. Background is going to be sun damage. It exclusively arises on head and neck in chronically sun exposed individuals. And what you will see on high power is these fascicles of very bad looking spindle cells, which will have lots of pleomorphism and atypia and mitosis. So even though you're seeing the giant cells, they are very ugly looking. And that would be the clue. You can have areas of hemorrhage within the lesion. You can have a predominant fascicular pattern. So, and then remember, this is a diagnosis of exclusion, right? You have to make sure it's not a bad squamous cell. It's not a bad melanoma. It's not a leiomyosarcoma, and it's not an angiosarcoma. So you have to exclude all those tumors before you diagnose an AFX. So AFX is a mimicker of a granulomatous neoplasm. The other thing which could mimic a granulomatous neoplasm is another tumor, which is your granular cell tumor. So your granular cell tumor is going to be a tumor which is actually derived from the Schwannian cell. So it's S100 positive. And the presentation of this tumor can also be variable. So it can look like clinically, you can think about a cyst, or it may look like a neoplastic entity, like a squamous cell. And that happens when there is lots of epithelial hyperplasia. Now, books will say that it incites a lot of pseudoepitheliomatous hyperplasia, but that is not always the case. It can do that, but it may not always. And it's a dermal or a deep dermal or a subcutaneous based lesion. But when you go up on high power, the cells, the reason we think about that they are granulomatous is because they have lots of pink cytoplasm. But what is inside the cells is completely different. What do we see inside the cells are these pink granules. So the granularity is very predominant. And then a classic finding for a granular cell tumor is the presence of these pustulo-ovoid bodies of Millian, which are these perinuclear pink inclusions. So you see these nuclear inclusions. This is diagnostic. So whenever you see a granular cell tumor, you have to make it a point that you're seeing the pustulo-ovoid bodies, because that's pretty diagnostic, what you see here, the pink inclusions. And all these granules are lysozymes. So these are all lysozymes which are stuffing up these immature, arrested in their development Schwannian cells. So these cells are going to be S100 positive because it is Schwannian in origin. So this is actually a neural tumor. So this is a granular cell tumor. That's a very, very important board question. Another entity which can mimic a granulomatous process is going to be your hibernoma. So a hibernoma is a tumor of the brown fat. So it has a classic, the white adipocytes, and then the second type of cells, which will have this mulberry or spider web-like appearance with these intracytoplasmic web-like extensions. And the other entity which this mimics is a silicon granuloma, so which I'm going to show you side by side. And we will talk about silicon granulomas more when we are doing iatrogenic entities, but this is a classic hibernoma. And again, a hibernoma is one of those entities, if you've seen it one, you will always remember it. So let's look at silicon granuloma. A silicon granuloma is basically iatrogenic entity, right? And what it looks like, so a hibernoma is a true fat neoplasm, but a silicon granuloma, even though it looks very fatty, is not really fat, and it is fat-like spaces which are produced by these variably sized silicon droplets. So a lot of variability in the size of those fat-like spaces. So you see very big, you see small, you see really tiny. That's the first clue. And that is what gives it a fat-like appearance. And that's what gives it a Swiss cheese appearance. It looks like, you know, these holes and spaces look like Swiss cheese. And if you go around it a lot, you will see that there are granulomas and giant cells percolating in between these spaces. So that is your silicon granuloma. So you actually see true fat necrosis and a histiocytic infiltrate. So that's a silicon granuloma. So that can mimic, a fatty tumor. Okay, and then another entity which is a mimicker of a granulomatous disease, though you guys don't find it too confusing, you most often do recognize it unless and until it's very challenging, is a dermatofibroma. So a dermatofibroma can look like a xanthoma or a xanthogranuloma because it can have a lot of the fibrohistiocytic cells. So it is a fibrohistiocytic neoplasm, right? So the background cells which are forming a dermatofibroma are very similar to what you would see in a xanthogranuloma, except that in a xanthogranuloma, they're very juicy appearing, right? But in a dermatofibroma, they're more spindled. And another findings of dermatofibroma would be like the induction and then the nice collagen trapping, which you would see at the periphery of the lesion. But a dermatofibroma within itself can have a good degree of it can have these cholesterol clefts, mimicking a xanthoma. It can have a lot of foamy histiocytes, like what you see in here, as well as the Teuton giant cells. One of the variants of a DF that they really like to ask you, which can be a little challenging, is a hemosiderotic variant of a DF. This variant of a DF always looks very cellular and it has lots of blood in it. But again, low power view with the induction and the collagen trapping is a nice recognizing feature. And up in the middle of cellularity, when you see this degree of hemorrhage and inflammation with these histiocytes, you're never ever dealing with anything malignant. So even though the cellularity scares you, but if you see hemorrhage and hemosiderin, DFSPs will never do that. DFSPs are very monomorphous tumors. So just a clue that you're dealing with a hemosiderotic variant of a dermatofibroma. Another entity which can mimic your granulomatous neoplasms is an infection, one kind of which we just talked about. This is the other spectrum, and this is lepromatous leprosy. So lepromatous leprosy, again, we will cover it again when we do infectious disease, but I want to talk about it over here because number one, it is strikingly contrasting from tuberculoid leprosy, what we saw, which had the beautiful tuberculoid granulomas with no visible bacteria. Lepromatous leprosy, on the other hand, is opposite. First of all, it produces a very nice Gren zone. So you can see this uninvolved area of the dermis between the epidermis and the dermal infiltrate. And then you also have the a sheath of histiocytes. So it is the body has like minimal immunity. So it doesn't mount much response. And you have this sheath of histiocytes. And in the background of this histiocytic infiltrate, you see what are known as the globoid cells. The globoid cells are these histiocytes which have phagocytosed the bacteria. So you can see the leprabacilli appearing as this cotton fluffy organism. So these are called globoid cells. So you don't actually even need to stain it up. You obviously will stain it up. You will do a fight and these will be fight positive, but you don't need to because you can actually see the organisms in the infiltrate. So why am I talking about this is because this entity, lepromatous leprosy, will also produce you a back-to-back granulomatous infiltrate with a lot of histiocytes. So you have to look inside the histiocytes to see what they contain. Do those histiocytic looking cells, do they have the tiny granules of a granular cell tumor? Do the histiocytes have bacteria in them for lepromatous leprosy? Or do the histiocytes have lipid in them for a xanthoma? So then let's talk about a xanthoma. So this is the last thing we are going to talk about today. So a xanthoma are diseases which are truly made up of one kind of cell. And that one kind of cell are your lipid containing cells. So whenever you have a xanthoma, you do think about a lipid disorder, right? And that's where, again, in your PowerPoint, you have to basically remember this because they like to ask you xanthoma and their associations. So eruptive xanthomas, tuberous tendinous xanthomas, xanthelasmas, and planar xanthomas. Each one of them is associated with some kind of a lipid disease, which you need to remember. The histology of this is pretty simple. The histology is one kind of cell, which are the lipid-laden histiocytes with variable degree of cholesterol clefts outside the cells. Now, tuberous tendinous and planar xanthomas pretty much look the same. These are large, bulky, multinodular lesions and presenting as a nodule. And what you see is this sheets of histiocytes, which are of one kind. They all contain lipids. So the foaminess of the cytoplasm is important. So what is inside the cells is foaminess, is the lipid-laden histiocytes, which produces this kind of like a vacuolated cytoplasm, and it's variable. Some cells will have a lot of lipids, so they look like really, really white. Some have less lipids, so they look more pink. And you will also see Teuton giant cells in the background. And then, if you get really lucky, you will see these nice cholesterol clefts, which are like slam dunk for a histocytic disorder like a xanthoma. So you can see these giant cells, the cholesterol clefts. As these xanthomas become older, these histiocytic cells may be replaced by areas of fibrosis. So the lesion may have a more multinodular appearance where you see fibrotic bands, and then you see nodules of these cells which have lots of lipid in them. Xanthelasma is a very important question that they like to ask you. And xanthelasma, first of all, you easily recognize it by its location. It's the eyelid skin. So you see a very thin epidermis with tiny, tiny villous hair follicles. And in the dermis, around the vessels and around the hair follicles or in the interstitium, you see these aggregates of cells which will have this foamy cytoplasm, which are all lipid-laden histiocytes. So again, it's a diagnosis that you guys quite often don't struggle with because of the location, the nice thin epidermis, and then you see these are all lipid-laden histiocytes. Out of all the xanthomas that we talked about, probably the most difficult one is an eruptive xanthoma. So eruptive xanthomas are almost like your primitive xanthomas, right? Because they're not very well formed. As the lipid level goes, triglycerides go up, the body erupts and throws out these xanthomas. So they're more primitive. So at low power, they will look like a busy dermal appearance. So you often actually think about GA because it produces you a busy dermis. But when you go up on high power, the diagnosis is pretty simple. You see the histiocytes, which are not really white because they're not very well formed. They do have lipid, and you can see that the foaminess to the cytoplasm. They may be very well formed, but most often they are not. They look more pink, but you can see the foaminess of the cells in here. And again, they can have variable degree of the cholesterol clefts. And then last of all is a very nice entity, which if you have seen it once, you will always remember it, and that's your verruciform xanthoma. So verruciform xanthoma, even though it has the word xanthoma in it, has got nothing to do with the generalized lipid disease. These are localized entities which occur in the intertriginous sites or in the oral cavity or in the genitalia, and they are associated with localized destruction of epidermal keratinocytes, which are releasing the lipid and which gets phagocytosed by the histiocytes. The morphology of the lesions is very classic. The low power looks like a wart. So you can see this Bruch's hyperplasia. Another classic appearance on low power are these columns on fire. So you can see these broad parakeratotic columns, which look like really like flames, big flames, but they also can make you think about cornoid lamellae, like porokeratosis. So sometimes I've seen people getting confused with that. Okay. But in between these columns on fire, the expanded fingers of the dermal papillae, if you pay attention to the dermal papillae, will have sheets of these foamy histiocytes as you see in here. So that is your verruciform xanthoma. So on low power, it looks like a wart, which looks like these broad columns of pink. And then when you go up on high power, the dermal papillae will have the foamy histiocyte. So that's a verruciform xanthoma. So with that, those were the entities that I wanted to cover in granulomatous diseases. I think I have sent you guys 2 study sets, granulomatous 1 and 2. Did you guys get it? Anthony should have sent it to you guys yesterday. If he's not, then
Do
Cassidy,
you know
do you
what
have
those are
it?
titled?
What is that? Granulomatous 1 and granulomatous 2.
Okay, yeah, we don't have those ones. We now have the SP1, SP2, SPB1, SPB2, SP test.
Okay, but you don't have that. I'll send Anthony. He's right here. I'm going to tell him to. He probably just forgot. I'm going to tell him to send it to you guys. So you should have granulomatous 1 and granulomatous 2.
Okay, thank you.
Okay. So next week, I think we will go through some slides. And I think I already told you, but I'm forgetting. What did I tell you? What slides it will go through?
I think you said SPI B1.
SPI, didn't we do SPI B1?
Yeah, I think it's B2.
Yeah, B2. I think.
B2.
We will do SPI B2, right? Okay, we'll do SPI B2, but just be prepared for like any of those SPIs also. Okay?
Okay, sounds good. Thank you.
Thank
Well,
you.
Thank
Thank
you.
thank you
you.
guys.
Thanks.
You have a good weekend.
You
You
too.
too.
Thanks.
You too.
Yeah. And I think this session was recorded because we went through so many entities. I know pretty much your brain is probably on fire. So I can have that recording available to you guys so you can, go back through it and slow me down and listen to me if you want to listen to me. So,
Yeah, that'd be great. Thank you.
okay. Thank you. So I'll send the recording as well.